Brad, are there prognostic factors to use the index for mantle cell index, International Prognostic Index, to help you guide what therapy you use? I mean, is it the Ki-67? Is it, as John was alluding to, the p53 mutations? Is there anything that helps you figure out what therapy and how you should be doing something differently in one patient than the next?
I wish they were really helpful. I do think the TP53 mutation is a very important baseline parameter, and it's more useful in telling you what not to do than it is in telling you what to do. But we know now from some large mature data sets that, to take a patient through intensive chemotherapy and an autologous stem cell transplant, if they're p53 mutated, is just not a good strategy for that patient. So you should try something different. Now, what that something different should be is less clear. I think you could make an argument for some strategy that doesn't involve DNA damaging agents to rely on your cell kill. So BTK inhibition or lenalidomide, and then maybe even consider allogeneic stem cell transplant or CAR T if you could find the right study. But you need a fundamentally different approach than our traditional approaches if you have somebody who's p53 mutated. Regarding the MIPI, the mantle cell IPI, it's often not helpful in telling you, how to manage a patient, but sometimes you're on the fence. You might have a 65-year-old patient and you're trying to decide whether you should be intensive. Maybe they have some comorbidities. You're trying to decide whether to be non-intensive because of those comorbidities. Maybe if they were more favorable in their MIPI, you might lean toward the non-intensive approach. If they were less favorable, you might lean toward the intensive approach. And so I do find there are some patients who I'm struggling and decide how aggressive to be with their treatment. Sometimes then I'll use the MIPI to help, break the tie.
So the blastoid variants and the pleomorphic variants, I find tremendously difficult to know what to do. And unfortunately, you can say, well, you shouldn't do this, but in reality, you don't. The alternatives are not all that attractive. Right. What do you think, Matt?
Yeah, I mean, this fortunately is a pretty rare group of mantle cell patients, but we do see them, and it's very challenging to treat. They may have a transient initial response to these regimens that we've talked about, but they almost always recur fairly quickly. And so I think for those patients, if you have a center that you refer to and there's a clinical trial available, I think that's probably the best thing for the patient, is to explore these novel regimens.
So the average community oncologist probably doesn't see that many cases of mantle cell lymphoma a year, let alone or in their career. Brad, what advice do you have for the community oncologists and as they see someone with mantle cell lymphoma?
Well, certainly if it's a young patient who would be considered a candidate for an intensive strategy, to send them in early so we can assess their fitness for stem cell transplantation. We can start working through the insurance approvals and all the issues that go into that. So it's better to see them early. Certainly we like to see them so we can consider them for clinical trials. There's still lots of room for improvement in mantle cell lymphoma, and so to the extent we can find appropriate trials for patients, we like to have that opportunity. I think most community oncologists are comfortable with the bendamustine rituximab regimen, and that's a perfectly reasonable thing to do for an older mantle cell patient. But I would encourage community physicians when they have a mantle cell patient, whether it be frontline or relapse, just to check around and see if there's an appropriate clinical trial, because it is a lymphoma still where even though outcomes have improved tremendously, you said that earlier and you're absolutely right, there still is lots of room for improvement in mantle cell lymphoma.
Yeah, and do you think that the strategy, every other disease, we just talked about CLL for a while here, we're moving these targeted, more novel agents frontline and getting away from the cytotoxic chemotherapy. Do you think that's just a matter of time before we get away from the bendamustines or the cytarabine-containing regimens and transplant? Do you see it differently?
It could happen. Michael Wang at MD Anderson is studying some of these really innovative approaches where he's doing a window study where he's starting with novel targeted agents, and then he's trying to truncate the amount of intensive chemotherapy that are given to patients, and he's shown that the response rates to the targeted agents are very high. Now, we don't know what the long-term outcomes are yet, so I guess I would encourage people not to rush to those kind of strategies until some of the data that's currently being generated is mature and we know that it's a good strategy. And hey, I would love to get away from chemotherapy as much as anybody else, but the fact is our strategies are working fairly well in mantle cell, so you don't want to subtract what's working until you know that what's coming along is at least as good, if not better.
And it's not an easy question to get to. Right? I mean, you have to be pretty sure of your therapy before you pull away from what we've done because of the improvements that we've seen. There are trials, though, that are looking at the BTK inhibition with venetoclax and other things as frontline. John, do you have similar thoughts as Brad on this?
I do. I would say I think it's very, very important to really make sure that we're not burning a drug too soon. In other words, keeping something in our back pocket, especially for those high-risk patients as well. So I'm not sure that it's going to play out to have BTK inhibition as part of the frontline regimen, but if it does, it will be with chemotherapy, I think, for the immediate future. We'll see if it allows us to give less chemotherapy than we might. I think that might be appealing. But if we're going to do that, we really actually need to have this idea of being able to stop treatment too, not just continue the BTK inhibitor indefinitely in mantle cell, just like we're hoping to do in CLL.
I looked at Michael Wong's data, and of course you look at it and you say, well, the next option is definitely going to, if you're reducing, and then the question is, can you just get rid of that ARC at all, at least for a cohort of patients that achieve a CR. Right. There was many more that improved with the addition of the hyper-CVAD, but it really would be attractive. You can certainly extend this therapy to a much wider age group than you can with these very intensive regimens.